Okay, we're going to have just a brief discussion about cardiomyopathy, various types, and you'll see listed in your book dilated cardiomyopathy, hypertrophic cardiomyopathy, and that can be divvied up into obstructed and non-obstructed. And some of the hypertrophic cardiomyopathies are some that occasionally you'll see an athlete that will, kind of drop dead during the middle of a workout or something. Some of those are attributed or thought to be attributed to the hypertrophic cardiomyopathy. Then there's the restrictive cardiomyopathy, and then the arrhythmogenic right ventricular cardiomyopathy, or also known as cardiac dysplasia. And this also usually affects young adults, and there is a familial association with that. So we'll just briefly discuss these. I don't want y'all to get all bent out of shape trying to learn all of these. Basically, what cardiomyopathy means is that there are some chronic changes that have gone kind of maybe unattended or unnoticed until they do some damage and start showing effects. But there's been changes in the muscle of the heart itself, structural changes. It's either gotten fatty or fibrous or hard or thinned out or whatever. So generally, of course, it can affect the atria and the ventricles, but certainly we notice it more when the ventricles are affected, because that's what is the workhorse of the heart that pumps the blood out to the body. So certainly that will affect the cardiac output. So the four types are explained in IGGI. These are the pages 767 through 769. It's not a real hard read. I suggest that you read over it. There's also a table, 37-5, that shows pretty good indication and some good information on it. I have a little different table, which is a little more inclusive, but you're certainly welcome to look over both. So what happens? We said that the heart muscle itself has some changes. It's not able to do its job. We start seeing cardiac output fails. And so just essentially the heart loses its ability to pump blood as it should. A lot of different causes, probably some are even unknown, but high on the list are alcohol abuse, chemo, infections, people that are poorly nourished. There's also a genetic disorder, and the immune system, when that attacks things like lupus and that kind of thing. So a lot of different reasons high on the list: alcohol abuse, chemo, and infections. Okay. Quickly, this is a little different than the picture that's in your book. I think this one has a little more information on it. The dilated cardiomyopathy is there first, represented here by this picture. Then the obstructed and non-obstructed together in this picture, and then the restrictive myocardiopathy. So looking at the dilated, as you can see, the ventricles, all the chambers are dilated, so they're big, and that thins out the musculature of the ventricle and even the septum. So it doesn't have the muscle strength to do the job that it should to push all this blood that can accumulate in here. So you can see we'll have the thrombi can be formed in there, because there's going to be some blood left in here to sit and coagulate. So that's a problem with it. You see that the signs and symptoms: fatigue and weakness, heart failure of the left side, dysrhythmias, or even heart block. And of course, embolize can give you some S3 and S4 gallops, and it can even progress to be severe. See what the treatment is. They're going to treat it like it's a heart failure. They're going to give diuretics and meds to help it beat better and more efficiently, vasodilators, controlled dysrhythmias, and as later in the last resort, heart transplant. These are the patients that are most often sent for heart transplants. Okay. Now the non-obstructed and obstructed, like I said, don't get bent out of shape learning all these highfalutin differences. The one major thing, they're treated very similar to how they treat the dilated, okay? Except, here's the one exception. In the obstructed form, we do not give digitalis, nitrates, and other vasodilators. They are contraindicated in the obstructed form, okay? So, in the non-obstructive, they've got, as it talks about in the title, hypertrophic, meaning that the muscle has become enlarged. And you see how that septum is big and the outside walls are so big? Gosh, there's hardly any room for any blood to get in here. So that's a problem, isn't it? So when that has happened, even the septum, it leaves you just a little bitty chamber in here. And as you can imagine, we get short of breath. They have angina. They may have syncope, palpitations, all these kind of things, and an S4 gallop. So very often, look, this is important, sudden death, very often because of this heart failure. So they treat both forms the same. Treat the symptoms, beta blockers, conversion if they've got atrial fib and if they're a candidate for that, except for the obstructed one. Let's see, here the obstructed, it says that except for obstruction, let's see, left ventricle outflow tract associated to hypertrophic septum and mitral valve incompetence. So it's the same treatment, except that we don't give the nitrates, digitalis, and all that. That's about what I'd want you to know the difference of those. Then the restrictive, there again, it mimics kind of pericarditis, constrictive pericarditis. There's fibrosis in all these walls, and it can't contract. So the chambers get narrowed, and then emboli again are common. So that's a thread we're seeing in all of these, because the heart can't do its job, can't pump the blood out, so some sits in there and they can form little emboli. Okay? We're going to have to help these clients to learn to regulate their activities so that they won't be so get so whooped from walking around the house or to fix something to eat or to the mailbox or whatever. They need to gauge how much rest they need, stop, take a rest, to recover, and go on. So that's going to be a real big thing with teaching these clients. Now, my picture and the picture in your book didn't have anything about the arrhythmogenic right ventricular or the dysplasia. So here's a picture that Miss Gist found, and I'm not going to hold you to knowing what an epsilon wave is, but you can see it's caused here. And here's the reason, because it's all this chaotic heart muscle and fibrous and fat and all. Sometimes on these x-rays it'll show up also. You can see the fat and everything. The trained eye can, I couldn't. But anyway, they have flip T's on a 12 lead in V2 and V3. I'm not going to expect you to know that, but I'm just saying, that it can happen. The epsilon wave is right here after the PQRS, and it's kind of right before the T, sort of embedded in part of the T. That's called an epsilon wave. But and you can see this young man, big robust guy, and he says, "My jock brother died in his sleep. Could I be next?" Well, this is the one that it is familial, so that could run in families, and it does affect young adults. So we wouldn't be telling him, "Oh, no, absolutely not. It's not going to happen to you. Don't worry." No, we're going to suggest that these folks get looked at and seen if this has happened in their family. Okay? So, looking at the cardiomyopathy in general, the signs and symptoms, they certainly vary by how far along, what type and how far along the cardiomyopathy is. A murmur may be the first indication that there's any problem. Okay? And I'm certainly not expecting y'all to know, this, that, and the other, but need to be able to recognize that there is a murmur. The dilated type, progressive dyspnea, they get short of breath with exertion. They have to sleep on pillows. They get palpitations. They really have a low tolerance for activity. And if they have right-sided heart failure, they're certainly at risk for AFib, and embolisms. We know all those signs and symptoms. The hypertrophic, they also get short of breath, and angina may be atypical, so they may be not as easily taken care of and get their angina to resolve because it is atypical. Syncope, and any time a patient has syncope, be they a cardiac patient or just any patient, syncope needs to be investigated. Syncope is not normal. Okay. Restrictive, we're seeing all the same, short of breath, that kind of thing. Restrictive dyspnea, fatigue, also right-sided failure, the gallops, emboli, all same. The only one that's a smidge different, and really they're all very similar. Palpitations and syncope, and can lead to heart failure in the later stages. All of these, this is just not a good thing when your heart is big and oversized and not functioning well. It is just not a good thing. Here's some links that you can go to, and here's some murmurs with a hypertrophic heart murmur. I think that would be, I think that's polycystical or whatever, where you kind of hear it all over when you're listening. But you can go and listen to that. What about treatment? Okay, the little page that I showed with all the pictures on it, that kind of gives you a good indication. This just sort of recaps that. Dilated and restrictive, we treat them the same. Diuretics, vasodilating agents, cardioglycosides, because what we want to do is increase the cardiac output. That's what we're on the short end of the stick of cardiac output, so we want to increase it. We may give beta blockers to help treat their tachycardia. For the hypertrophic, both types, the blocked and the obstructed and unobstructed, we're going to give beta blockers and convert them if they're in an AFib, to see if we can't get them to convert either with drugs or cardioversion. Remember, I said that the obstructive hypertrophic cardiomyopathy, we do not use vasodilators, we do not use diuretics, we do not use nitrates, and we do not use cardioglycosides. Those are contraindicated in the obstructive cardiomyopathy. Now, as far as surgery goes, they can go in, and pretty much they can go in and do, like in the septum of the heart, they can go in and take out some of that to give a little more room in there. You know, they can, that myectomy means go in and clip out some of the tissue, so that can give them more room. Also, the percutaneous alcohol septal ablation, that's kind of the same, gives the same effect. Transplantation. These, like I said, a heart transplant might be the answer for some of these patients. But remember, they do look at who are candidates. Who are they going to give hearts? Hearts are not that available. Who are they going to give them to? Remember, we said some of the causes of these clients having these problems are alcoholism, that kind of thing. So, you know, if they're still pretty much an active alcoholic, or do you think they're going to put them high on the list to receive a heart? No, probably not, unless they're very famous and have a lot of money. That's my thought on that, and I'm going to stick to it. Okay, the nursing, I also didn't mention the chest x-ray, echocardiogram, and cardiac cath. And echocardiograms are just wonderfully non-invasive tests that give a wealth of information, so that these are going to be some great ways that they'll diagnose these and help to guide their treatment. Nursing management is going to, things we know what to do with. We know how to take vital signs and assess. So the heart rhythm and the rate, very strict I&O, because these clients are very fast to go into heart failure. So intake and output, and any sudden weight gain, that kind of thing is going to be a big thing for us. O2 saturations, giving them O2, assessing their edema, and not just saying, hey, they're edematous. You know, we need to say, where is it located? Is it, all the way up to the knees? Is it all the way up the legs? Is it pitting? How much? 1+, 2+, 3+. So we need to be very descriptive in where and how much edema is going on with these clients. And certainly a big thing that is really big deal. Of course, knowing about their medicines and diet and activity and all, but teaching them how to manage their activity, give them some ideas. People have been doing things the same way for 50 years, and, it may not occur to them that, hey, you need to slow it down. You need to do this and take a 30-second rest or a 2-minute rest or something. So we need to intervene and put these thoughts in their heads. Okay, that's all I have for you right now. Thank you.